Hi guys, my name is Mami. I'm one of the second year PEM Fellows. I don't think I've met all of the first years yet, but we're going to do a topic on hematuria. We are going to start with just like first a quick question and then go through a few of the differential diagnoses, go through some initial testing, and then a case presentation while we work through the workup. Shout out to Dr. Rallo for giving us a nice intro. So this helps the first question, because if you guys were paying attention, you should be able to kind of get at least most of this. Okay. All right, so I'm going to read this question and then you guys just try to answer it and then we'll move on. All right, so we have a 15-year-old male with no past medical history who presents to the ED with 2 episodes of red-colored urine. His mom is alarmed by the urine, but also confused since he otherwise seems fine. He has no abdominal pain, vomiting, dysuria, or fever. Vitals are within normal limits. His exam is normal, including abdomen, which is soft and non-tender. Which of the following dietary factors could explain the red discoloration of his urine? So A, beets, B, mushrooms, C, blackberries, D, peaches, E, A, and C, and then F, A, B, and C. You guys can throw some answers in the chat or call it out if you want. Okay, we have one. Anyone else? Do you guys agree, disagree? All right, we'll go with Sean's answer. Let's see. All right. So yeah. So a lot of people usually, guess beets and blackberries, even for myself while doing this. Didn't know much about the mushrooms, but some mushrooms can cause red stain to the urine. So obviously beets and blackberries, and specifically for the mushrooms, the saffron milk cups, which I'm not really familiar with, but apparently some people cook. But in addition to like actually red stained urine, you can also have certain mushrooms that cause microhematuria without necessarily having that like red stain. And there's some that I've listed here. And I think the Amanita phalloides is the one that they talk about in like step studying being a toxin. All right. So you get a patient that comes into the ER with red colored urine. A lot of the times, triage will put as a chief complaint like hematuria, irrespective of like whether it's like true hematuria or not. So the first question you should ask yourself is this hematuria or not? In terms of definition, so in order to be able to answer this, it's important to know the definition. So hematuria is known as greater or equal to 5 RBCs per high power field. The literature shows that there's like some variation. So some people, like the American Urology Association, will go with 3, but like the general consensus is more than or equal to 5. Persistent hematuria is known as greater than or equal to 5 RBCs on 2 separate exams. And then macroscopic or gross hematuria is anything that's visible to the naked eye. And then microscopic is one that is detected by UA or microscopy only. All right. So for microscopic hematuria, the incidence is about 4.1% of school-age children. Of course, it varies given like different factors, so like age, gender, et cetera. And then for those that have it on more than one sample, it's a little less, so 0.25 to 1%. And then in terms of gross hematuria, 0.13% of children in pediatric visits. And then it's also more common in boys. In terms of classification, clinically, it can be classified as gross or microscopic. So with microhematuria, it can be either incidentally discovered, you can have it with symptoms, you can have it with intermittent gross hematuria. And then for gross, it can be intermittent or like continuous. In either scenario, a patient can have hematuria with a little bit of like proteinuria as well. And then in regards to like pathophys, you're thinking of it in terms of like glomerular versus non-glomerular. causes. Sorry if my mouse is like on the opposite because I'm using the presenter view. Um, so yeah, next slide. All right. So this is an exhaustive list. I put it all on one slide of all the possible causes of either red urine or hematuria. It's organized into categories. So you have your glomerular causes, your upper urinary tract, your lower urinary tract, and then external, a few external, and then the factitious, which we're going to zoom in and go over in the next few slides. All right. So we have the glomerular causes starting with strenuous exercise. And this one specifically, keep in mind that it's a little bit different than your exercise-induced rhabdo. It's different in that this one, there is presence of RBCs in the urine following like physical activity. So whether the athlete or the student had like mechanical trauma to the bladder, renal system, you can have the blood that's spilling. This is typically benign and self-resolving. It usually should resolve in about 48 to 72 hours. And this is in contrast to myoglobinuria, which has no RBC. And it's just the reactivity of the myoglobin that's causing it to be positive for blood. You also have no real like systemic symptoms. So like in myoglobin, you can have your electrolyte imbalances, but remember for strenuous exercise induced, you have the RBCs that are still intact. So you're not really spilling the contents out. All right, so the rest of the list, so you have other glomerular causes, so acute post-strep glomerulonephritis, IgA nephropathy, thin basement membrane disease, and then more uncommon to like Alport, where you'll have like hearing loss or family history, MPGN, and then other things like more systemic like lupus or vasculitis. In terms of the upper urinary tract, so you can have, pyelo. I'm going to just go through these quickly. Renal trauma, a UPJ obstruction, and then your hemoglobinopathy, so like sickle cell disease, where you can have nephropathy or papillary necrosis. And then uncommonly, you can have your interstitial nephritis from drugs. These are a lot of drugs that we prescribe in the ED. So some NSAIDs, penicillins can cause this. Masses or like cysts, coagulopathy, renal vein, venous thrombosis or arterial thrombosis, and the nutcracker phenomenon, which Dr. Raul covered nicely with the compression between these two arteries here of your left renal vein. All right, so then here we have the lower urinary tract. You can see more commonly with like iatrogenic hematuria, so like bladder cats, Foley cats, cystitis, perineal trauma, urethritis, terminal hematuria, trigonitis, which I'll go into more in depth later, which is usually, well, essentially at this location. Where's the location here? And then you have your bladder tumors and a lot of different things that are in the lower region as well. All right, so factitious causes. This was our initial question stem, knowing what is like not true hematuria and the different things that can cause red stained urine. So you can have endogenous pigments, so myoglobin, rhabdomyolysis specifically, and this one would have the contents that are spilling out of the cells. Hemoglobin, biopigment, uric crystals. So for this one specifically, for the uric crystals, you will usually get it as like a first time new mom, a new baby, maybe like the first 1 to 2 weeks, and mom is saying she noticed this like orange pigment in the diaper. So your job is to make sure you're asking specific questions, asking about feeding, frequency. Is the baby latching? Does mom feel like she's emptying her breast? And then is the baby making wet diapers? This one's a big one for hydration status. Take a look at the growth chart, compare what the baby's current weight is versus what the baby was when they were born or discharged to see how, mom is doing. And then you can give her better education, resources like if she needs closer follow-up or lactation. And then you have other exogenous pigments, so like drugs like rifampin here on the right, and then sulfur drugs. This image here is serratia, which is a common cause of like UTI, pneumonia in certain hospitals. It's a harmless pigment, but the organism itself can cause certain infections. All right. So how do we narrow down our differential? I just gave you guys a laundry list of things to think about when you're having hematuria as a chief complaint. Majority of the time, your history can reveal your diagnosis even before you do any lab work. That's why it's extremely important to ask specific questions, knowing exactly how to cater them and like tease them out. Of course, you won't be able to ask like a million questions, but you should be having an idea of what to ask. So first, like blood on voiding, when is it? This hints at some type of glomerular or renal source if it's constantly bloody throughout the stream. Urethral bleeding is more likely either at the beginning or at the end. You can have symptomless terminal hematuria, which suggests trichonitis, which is the triangular part of the bladder that I pointed out to you guys earlier. Near the urethra, it can be caused by catheter use, UTI, or even like hormonal imbalances. And then was there a preceding infection like strep, which suggests post-strep glomerulonephritis? Was there concurrent URI or gastro, suggests IgA? And then any other like preceding factors like trauma to elicit whether there's contusion, myoglobinuria, voiding symptoms, just your frequency for UTI, renal colic or other pain for stones. And then this one, if there are like drops of blood or spotting in the underwear after or between the voiding, this can suggest urethral, which is sometimes can be caused by like trauma. So like straddle injuries or even certain urological procedures. In addition, ask about fever, rash, looking for signs and symptoms of systemic illnesses like lupus, HSP, any blood from any other sources, looking for coagulopathy. Prior episodes, you want to kind of categorize into whether it's like chronic or acute, and then medications, asking about sexual history for urethritis, and then family history is really important. I've listed some here. So Alport, I've mentioned already. Sickle cell, I've mentioned already. And then any history of stones or cystic kidney disease as well. All right. So in terms of your physical exam, you are looking for any edema on your vitals. You're looking for hypertension, tachycardia. This suggests some type of glomerulonephritis, renal failure, or volume overload. For GI, looking for organomegaly, ascites, any tenderness, masses, flank pain. Don't forget to do your CVA tenderness as well, because a lot of the times, you know, they are missed, and then you go back and do it, and then you elicit that. Blood at the urethra, expose the diaper, or, you know, take down the briefs and take a look, make sure there's no bleeding there as well. And then sometimes you can have a tourniquet from like a hair in a newborn. Those are important, but not necessarily causing hematuria, but this is just something to think about. And any breakdown in the skin as well. All right. So hopefully at this point in the encounter, you've, you know, asked your history, you've narrowed down, you've been able to narrow down your differential through history and your vitals, your physical exam as well. And at this point, depending on what we've been able to include or exclude, so like uric acid crystals, for example, you can exclude certain things. You do need a little bit more of a workup to exclude factitious versus other things, or narrowing down your differentials further. So this is where the urine test, urinalysis becomes handy. It's the first thing that we should think about. I think you guys are really good at ordering, you know, the urinalysis whenever there's like hematuria or even like presenting it. Before we get into the diagram here, so this image on the left here, it shows like an RBC filled urine versus hemoglobin filled one, and they look pretty identical. Like it's hard to tell which one is which. And then in this, right next to it is a centrifuged image where you can see that with the ones that have the RBC, the sediment, the RBC settle at the bottom versus the hemoglobin, which is like still persistently stained. So you essentially have your centrifuge result, which will tell you whether there's RBCs or not. And the dipstick also helps in determining whether it's true or not. So like blood or not blood, sorry. So if it's negative, then it'll be like the beats or the stains or all those pseudo causes, versus if it's positive for blood, but no RBCs, then you're thinking more in line with myoglobin or hemoglobin. The myoglobin and the hemoglobin, they just, there's like a peroxidase-like activity that just mimics and reacts to the strip, which causes it to say positive, but when you really take a closer look, there's no RBC. And then here's an exhaustive list. I'm not going to go into this because we've already touched on that already. But remember that for the urine, it can be bright red, it can be dark brown, it can be even like orangish. You can have a negative, so negative dipstick or like negative blood, negative RBCs, you have your stains. But then for the dark brown color, you're thinking of more of like alkaptonuria. We don't see that often, but just studying for exams, like the tyrosine disorders, or even methemoglobinuria. And then you can also have dark brown urine that is positive blood, but no RBC. So this is your myoglobin, your hemoglobin, which is like going through that dark color because it's going through the renal system. You have an exposed hemoglobin that's just reacting and going through processes that's making it darker and darker as it goes through the tubules. And then you can have, positive dipstick and positive RBCs, which will, look like cola colored, and we'll talk about that later. So you have your microscopy, your RBCs you want to look at. If it's absent, again, that's factitious. If it's dysmorphic, think of it as like bent shaped and has gone through the glomerular, so higher. And then if it's eumorphic, think of it as like not going through the glomerular and just in like the collecting duct or elsewhere. And then RBC cast is diagnostic for glomerulonephritis, but if it's absent, it doesn't necessarily exclude that because sometimes you can, depending on like the timing and different things, it can be absent. And then look at your white blood cells for cast, cystitis. In hematuria, you should be able to see some protein. So don't be alarmed if you do see some proteins, but it shouldn't be, crazy high. It should be 100 or less. There are some instances where you have some severe damage to the kidney that will result in having some protein spill. And then also in your urine tests, adding for culture as well to screen for bacterial infection. All right, so we're going to take a little quick break with the question, another question. So we have a 16-year-old athletic boy who presents to the ED with diffuse body aches and tea-colored urine for 2 days. His past medical history is remarkable for a strep infection that he had 2 months ago, exam, just like some calf muscle tenderness. Vitals are generally okay. Urinalysis shows red-brown colored urine, specific gravity 1.030, pH 6.5, 3+ blood, 2+ ketones, no proteins, and the microscopy shows less than 5 white blood cells. There are no casts or RBCs. Of the following, what is the next best step to obtain for diagnosis of this condition? So this is actually one of the board exam questions. Nice. I'm getting some answers in the group chat. So you guys put D, CK level. I think this question tried to throw us off by putting like the strep infection 2 months ago and all that stuff, but you'll see why it's important to, get the timeline and really tease out the question to see what they're trying to ask. And then obviously our urinalysis helped us with that. So no RBCs, right? So yeah, you guys are right. CK level, the patient's discolored urine with the positive blood, but absent RBC in the setting of calf muscle pain in an athlete is consistent with myoglobinuria, which is most commonly caused by rhabdo. So rhabdo, you guys are pretty familiar with. You have breakdown of the muscle tissue with release of the intracellular contents, just spilling into the blood, and then it releases myoglobin, potassium, CPK, lactate, phos, and uric acid. So numerous causes, so like trauma, infection, burns, electrical injuries, muscle exertion, surgery even, and then some other metabolic disorders. So again, just to reiterate, you'll have a positive positive blood on the strips, but no RBC on microscopy. And then you can also have electrolyte imbalances, so like life-threatening hyperkalemia with EKG changes, as we're seeing here on the right, hyperphos, hypocalcemia. You can have AKI due to the obstruction of the tubules by myoglobin, and you should be able to see like some granular casts as well, increased creatinine as well. And then hepatic dysfunction happens in about 25% of patients. Treatment, fluid resuscitation, and you want to avoid nephrotoxic drugs. So I thought I'd throw this little case report in here really quickly because I thought it was really interesting. We always think of rhabdo, like athlete, but there have been some reports of like viral illnesses causing this. So this one was a teenager who had COVID. He came to the hospital. He had profound like weakness, oliguria, and they found that he had severe rhabdo. His CK was almost 600,000, and his creatinine was 14.1. Potassium was 9.9. He was given a liter of fluids, calcium gluconate, sodium bicarb, 10 units of insulin, and kayexalate. And even by the time they transferred him to the PICU, his potassium was only 8. So they had to do continuous renal replacement therapy. But I thought it was interesting for you guys to, broaden your differential or broaden, the etiologies when you think of rhabdo. All right. So we've talked about pretty much all the factitious and initial testing. So now we can focus a little bit more on like true hematuria. We're going to go through a case that came to Kings County. I wasn't there at the time, but I was working at UHB, and a mom came in with her child who had like some regular like URI, but you could tell she had like PTSD. She was like traumatized, and she told me that her son previously had like this really bad encounter in terms of disease wise, not like management wise, but encounter at KCH. So I went through his chart, and I thought this would be perfect to help kind of go through how, to work up and think through this. All right. So we have an 8-year-old male with ADHD presenting to the ED with abdominal pain, emesis, and diarrhea for 1 week. So this was the beginning of his encounter in Kings County, way before I saw him. He had abdominal pain, periumbilical. It improved with ibuprofen, fever, rhinorrhea, and cough 2 weeks prior that mom mentioned. And mom said, a week ago, the PCP got a UA because there was some dark urine. It was dark colored, frothy, and it was present throughout the stream. Mom said she was told that there was blood, but she was pending other results. And then 2 days prior to coming to the Kings County, to the PDR, it had resolved. So no like gross hematuria at the time. She also mentioned this like rash that he had all over his face, arms, trunk, which was non-puritic, again, 2 weeks prior when he was sick earlier. No dysuria, frequency, fever, like swelling, trauma, no other like past medical history, family history, medications, or allergies. And I also left out a very important review of system information on purpose because I think through the chart review, mom didn't mention this before, but then it wasn't until like after certain results came back, and then she was like, oh, by the way. So I'll mention that later. I kind of want you guys to go through this. So in the ED, vitals, temp 99.7, heart rate 83, respiratory rate 20, blood pressure 113 over 81. SpO2 was 98%. And then just the pertinent exam findings had some pharyngeal swelling and erythema, but without exudate. The rest of the exam was within normal limits. All right, so can we get some takers on differentials? You guys can throw in the group chat if you can. So let me just go back to, like, if this patient came into the ED with abdominal pain, emesis, and diarrhea, and there's no wrong answer, it's just like, what are you thinking of? And even with this, like, chief complaint as well. Nice. Okay. Nice. I got a few answers. So some people are saying vasculitis, that's HSP, glomerulonephritis, post-strep glomerulonephritis. Nice. So, with this patient coming in, I feel like, a lot of the times, even just going back briefly, abdominal pain, emesis, diarrhea for 1 week with nothing else. A lot of the times you're thinking of like viral gastro, let's give some Zofran and let's reassess and see. But I think, like, depending on the team or how much you want to look at this, like how wholesome you want to look at the patient, you might either say, all right, PCP already got the urine, it's pending, they're following up with that, it's resolved. Like, is there really much we have to do for that? Versus you're thinking of this patient as a whole and you're like, let's just do a little bit more. A urinalysis is not really too much to ask for. So of course, viral gastro and everything that you guys have listed. So especially up here, which you guys were really good with mentioning. So yeah, plus these. And then of course, everything else. So the next thing is, what other, investigations besides urinalysis can help narrow down the differential? So this is an algorithm. This one was from UpToDate. It's pretty straightforward. There's another one on the next slide that's like a bit more convoluted, but so for this one, you are just thinking through your differential, asking, is there a history of trauma? Do you need to get CT, abdomen or pelvis? Any signs and symptoms of UTI, getting your culture, rechecking later, or having them follow up with the PCP. Any signs and symptom of like perineal or meatal irritation, give them reassurance, supportive care. Signs and symptoms of, stones, whether you want to do ultrasound, some type of film, or, further imaging, like CAT scan or anything. And then signs and symptoms of glomerular source. So you have your analysis results and you're kind of deciding, like, does this really, require further, workup? In certain instances, you might want to get nephrology on board and seeing if you need to, do additional workup. So like getting basic metabolic panel, checking for CBC, your complement, your albumin, ASO, because a lot of these complements will help guide you through the differential in terms of like the answer choices that you guys put in the group chat. It'll help, determine that. May not come back right away for your disposition, but, depending on how sick the kid is, you might be able to get away with that. Let me go to the next slide. So this one is I'm not going to go through this one too much. Dr. Sally was wonderful enough to, get me a more, detailed version where you can, clinically or like in real time, you can go through this and decide what you want to do. If it's like elevated CK, whether you want to admit or, follow up later, factitious causes here, and then going down to see which imaging, blood work, or further workup you should do. All right, so in terms of the ED course for this patient, so the patient was given Zofran and Tylenol, Cepheid was done, and then a UA was obtained. I think the attending overnight figured, let's just add the UA, let's give the mom some reassurance, and then we'll go from there. So the UA resulted, and as you can see here, you have the urine that's not really bloody, just like yellow. Appearance was just cloudy, ketone, so maybe a little bit of dehydration, large blood, a little bit of protein. Again, remember we said, less than 100 should be good for hematuria, like isolated. Leukocyte esterase, large, white blood cells, 121. You're asking yourself, is this some type of like infection? Red blood cells in the urine, 34.9. So yes, we do have some, true hematuria. And then no bacteria seen. And then some casts, 6 to 10 here, hyaline, granular. I actually spoke with lab to try to see if, do they ever really report RBC cast? And I got like into a little back and forth with the lab tech, but that's okay. Apparently this cast in the urine here is just for all casts in the urine. And for some reason, it doesn't specifically report like RBC cast. Irrespective of that, at this point, urinalysis results come back. Child is eating, drinking, and then mom is, she's like, oh yeah, he had a sore throat around the time he was first sick with white dots in the back. So at this time, given this information mom gives, and then given the urinalysis results, the overnight team decides to order additional workup. So like CBC comp, strep PCR, and ASO. The patient ends up with abdominal pain again. They decide to, plan to treat given, the white blood cells. They said their plan at the time was we're going to discharge if it's a normal renal function versus OBS if it's abnormal. The comp comes back BUN 69, creatinine 1.4, albumin a little bit low, 3.1. And then you have here leukocytosis, a little bit of anemia, so 9.3, 27 for the hematocrit. Platelets were normal at 176, and then here's the diff. So in terms of this, like if you do like the Menser's index, it says like maybe some iron deficiency anemia, but the MCV here wasn't really low. And then the Cepheid came back negative. They decided to obs the patient, decided to treat with 1 gram of Ceph, trioxone, consulted renal, and then with still the concern for post-strep glomerulonephritis being top on their differential. So is there any, do you guys have any thoughts or anything you would have done differently? I think the overnight team did a great job at, obtaining that urine, because I feel like depending on which institution or who was working, that could have just been something that would have just been like, okay, you can follow up with the PCP for the urine that's still pending, especially if the patient was like tolerating PO, eating, jumping up and down and doing fine. And then, so floor course, patient ended up going on the floor, got famotidine IV, maintenance fluids. I put question mark here because it was unclear if they started off with 1 maintenance or less, but it looks like later they did 0.5. Renal diet as tolerated, and they did an ultrasound, and then they added further workup. So the complements, ANA, total IgA, got a chest x-ray, and then the rest were pending. So this was the renal ultrasound. Nothing exciting here. Just like normal echogenicity. There's no evidence of like any calculi or any masses, soft tissue masses, no hydro. And then I didn't include the bladder here, but that was normal as well. They measured it, noted it was, within normal limits for the child. So we at least know that the kidney itself grossly was fine. All right. So I'm just gonna go through this. All right. So I'm going to talk about post-strep glomerulonephritis, since this was, the top thing that people were thinking about when this patient came in. All right. So what is the definition? So you have acute inflammation of the renal glomerular parenchyma due to deposition of immune complexes. So you have trapping of these circulating complexes in the glomeruli. Grossly, it can look symmetrically enlarged. Not always, but it's characterized by sudden onset of oliguria, hematuria, hypertension, and edema. Here in this image here, you have that kind of like lumpy bumpy that we learned during step studying with the immunofluorescence microscopy. Here you have all of these like immune complexes and white blood cells, just a lot of inflammation going on. All right, so in terms of etiology, it follows an infection of either the throat or the skin post-strep. These are specifically nephrogenic strains of group A beta hemolytic strep, specifically M1, M4, M12, M49. I don't think you're ever going to be tested on this, but these are the specific subtypes that do cause post-strep glomerulonephritis, because not all of them do. You essentially have a molecular mimicry between the strep antigens and the renal antigens that are, the glomerular tissue basically acts as antigen that's reacting with these circulating antibodies against strep. So here for pharyngitis, it's usually 1 to 2 weeks after a pharyngitis. And then you have your skin infection, so specifically impetigo, where you have, it can appear 2 to 6 weeks after. So whenever you see these patients who, let's say, they come in with just a strep throat, strep positive, always remember, like, return precautions. Tell them, like, look out for dark colored urine, because they may not know. They may just think the urine is just a little bit dark, but just like put that in their heads. Look for, swollen feet. That may happen later. In terms of epidemiology, so it can be sporadic or an epidemic. It has had declining incidence over the last 2 decades, happens in greater than 2 years of age, frequently found in boys 5 to 15 years. And then clinically apparent glomerulonephritis, it happens in less than 2% of children that are infected with strep. So not super, super common. Clinical features, you're going to have your hematuria. It can be smoky brown or cola colored. And then we'll talk about the dysmorphic RBC. We've talked about it already, but dysmorphic being, think of it as being smushed through the glomeruli. You can have proteinuria, mild to moderate. You shouldn't really have like a nephrotic range. If you do, then it points to something like some type of renal insult or like severe damage to the kidney. And then oliguria, which can be transient in about 50% of patients. And then remember, for peds, everything is just like different based on how big or small they are. So for neonates, less than 1 ml per kg per hour. And then for like older, less than 0.5 ml per kg per hour. So edema happens in 85% of the patients. You can have mild with periorbital or pedal. You can have severe with hypertension, pleural effusion or ascites, and then hypertension, in 80% of the cases, with headache, somnolence, changes in mental status, anorexia, nausea, convulsions. And of course, like with all of this, you have something happening to the kidney, and you've had activated your renin-angiotensin system. So like you have this, continuous feedback that you have to, do your thorough exam to make sure that patients are not having these complications. You can also have hypertensive emergency in 10% of the cases. So, in adults, you're thinking of like higher numbers. So like 180 over 120. But with the pediatric, you have to make sure that you are pulling up your chart. Luckily, we don't really have to do that in the ER. Well, we don't see that often, I should say. But usually inpatient, if they're dealing with this, you have to pull up the growth chart, pull up their height, get their percentile, plot it, and then see where they stand. And usually renal is really good at doing this and putting it in their plans. But with evidence of, end organ damage, you should be really concerned for hypertensive emergency. So like encephalopathy, heart failure, pulmonary edema. And then you can also have circulatory congestion, dyspnea, orthopnea, or, cough, tachycardia, gallop rhythm, or even basal crepitations. And atypically, you can have renal failure, nephrotic syndrome. Our urinalysis, we've already talked about. So for blood, consider, your renal function panel, looking at your BUN and your creatinine, your CBC, looking for mild anemia, leukocytosis, C3 and C4. C3 should be low in post-strep glomerulonephritis. The C4, typically normal, but there are some instances where it's like borderline low. And then your CH50 is low. So these are some, other differentials that with your C3 and C4 can help kind of put it higher in the differential or lower. It's not, specific. It doesn't say yet you definitely have this, but it kind of helps you kind of get an idea and support everything else that you were thinking of to begin with. In addition, you want to get your throat or your skin culture. I've never really done a skin culture for like impetigo because a lot of times, like clinically, you can just say it is. But you want to swab the throat, add your ASO titers. The ASO titers, which is anti-streptolysin O, is specifically elevated in throat infections, and it can be elevated 1 to 5 weeks after you get that infection, and then over several months, it'll normalize. For your anti-DNase titer, that one is specifically elevated in skin infections. And then chest x-ray to make sure there's no like complications, so like pulmonary edema or anything else like that. All right, so finishing up, this case. So this patient, he went to the floor, started on 0.5 maintenance, B1 creatinine was downtrending, and then the pending labs resulted. So ASO 269, strep PCR was positive. Sorry, I'm just noticing something that I added, didn't save here. The C3 was, I think, 14. And then the C4 was also like maybe 16 or 19. So it was like the C3 was definitely low because the range was like 86 to like 200s. So it was definitely low. And then the C4 was like slightly low. The ANA was negative, ruling out like, not ruling out, but like making lupus and other things less likely. And then ID was consulted because they figured, the strep had happened a long time ago. Should we start? When should we start? How much should we start? So the patient was started on penicillin 500 mg BID. So around like the first or second day, started becoming tachycardic, blood pressures 130 to 140s over 80 to 110. And then his SAT started dropping 88 to 93%. Patient started having some crackles in the lung. And at this point, the IV fluids were held. They also got a chest x-ray, which showed some curly B lines and then a little bit of like trace layering of pleural effusion, as we see with the blunting, a little slight blunting of the costophrenic angles here. They ended up starting the patient on hydralazine, and then this is after he received Lasix. And this note here is what Renal put in their recommendations, that if the blood pressure was greater than the 95th plus 12 mmHg, so estimated around 135 or 95, they could start him on the blood pressure. All right. So around day 2, going on 3, started getting headaches, persistently elevated blood pressures. They had concerns for hypertensive emergency. Blood pressure was ranging from 116 to 153, over 71 to 88. Transferred him to PICU on nicardipine drip, labetalol. Started at 100, wasn't really helping, went up to 150, and then fluid restrictions. Hospital day 4, they were able to, stabilize the vitals, stabilize the patient. Patient was asymptomatic, but he ended up with a fever 102.4. At this time, they weren't really concerned for like sepsis or anything. Like they just were more worried about like a viral illness. So they got a GenMark, which was also negative. So I don't really know what to make of that. And then let's go on to the next. And then on hospital day 5, he had to go back to the PICU because he kept having headaches. Blood pressures were through the roof, ranging 125 to 156, over 90 to 111. And then this was his second PICU transfer, got on labetalol 300 mg Q12 and the UA RBC. So I put this here because on the initial UA that we saw, if you guys remember, the red blood cells were only like 34, 35. And then while he was having his hypertensive emergency, it like increased to like over 1,000, so over 1,500 actually. So that's what we see here. But I thought that was really interesting. And then luckily on hospital day 7, with everything that the PICU did, he was able to be transferred to the floor. His blood pressure improved and it was consistently below 120 over 76. So he was discharged on hospital day 8. His blood pressures were, 96/74. BUN was at that point 20. It went down through like the chart review as low as 14. So this one here on the left side is the discharge, the last urinalysis before discharge. He was sent home on penicillin, Lasix, labetalol with blood pressure monitoring, and he was supposed to follow up with renal in 3 days. But then in 10 days later, he had another viral gastro, another episode of the color colored urine, and he was actually in the clinic for nephrology, and because of the viral gastro throwing up so much, they sent him to the ER, and I think he just had like a 2-day hospital stay, and then was discharged. But from like all the chart view, they weren't really that concerned. They were like, this can keep going on, like the lab work can, keep happening, but they just wanted to monitor him a little bit. So in terms of like overall management, which we've talked about, antibiotics, supportive therapy, diuretics, antihypertensive to monitor blood pressure. And then if this patient is admitted, daily monitoring, trending, not only the blood work, but also the blood pressures to make sure. Very rarely, I don't know the actual numbers, but they may need a renal biopsy if there are other, more concerning things. So if you think there's like a nephrotic range proteinuria, you need to investigate more, or other associated symptoms of like systemic disease. If the diagnosis is not really that clear, you might need to do a little bit more. In terms of outcome and prognosis, it has an excellent prognosis. A small proportion can progress to rapidly progressive glomerulonephritis, though. Edema and hypertension, you usually will get them in that first week or so, but it should subside within 2 to 3 weeks. The gross hematuria and the significant proteinuria should disappear within 1 to 2 weeks. And then the microhematuria. So if this patient was to come back later and they did a urinalysis, his you would see, a little bit of blood RBCs in the urinalysis, but you shouldn't be alarmed because this is expected. And then the C3 levels should normalize within 6 weeks. So this is actually, so 9 months later is actually when I saw the patient in the ER for some viral URI, and mom had like PTSD. She was just like, oh my God, like, can you please test the urine? I'm so nervous because this patient was my kid was in the ICU. So luckily, we did the urinalysis and everything had normalized. It almost was like this whole thing didn't even happen, which was reassuring for mom and myself as well. And then, so that is pretty much it. We were able to, go through the glomerular causes, specifically acute post-strep glomerulonephritis, gone through touch base on, imaging, blood work, things to do to differentiate, and specific history and exam findings that'll point you towards specific things here. And of course, the factitious ones. Remembering that no RBCs are present and no blood should be present for most of these. And I think that is the end of my presentation.